Hello, and welcome to Shadow Me Next, a podcast where I take you into and behind the scenes of the medical world to provide you with a deeper understanding of the human side of medicine. I'm Ashley, a physician assistant, medical editor, clinical preceptor, and the creator of Shadow Me Next. It is my pleasure to introduce you to incredible members of the healthcare field and uncover their unique stories, the joys and challenges they face, and what drives them in their careers. It's access you want and stories you need. Whether you're a pre-health student or simply curious about the healthcare field, I invite you to join me as we take a conversational and personal look into the lives and minds of leaders in medicine. I don't want you to miss a single one of these conversations, so make sure that you subscribe to this podcast, which will automatically notify you when new episodes are dropped, and follow us on Instagram and Facebook at Shadow Me Next, where we will review highlights from this conversation and where I'll give you sneak previews of our upcoming guests. Welcome to Shadow Me Next. Today, I'm excited to introduce you to a true trailblazer in the PA profession, Keri Hayes. Carrie is not only an accomplished interventional radiology PA, but also a dedicated advocate for advancing the role of PAs in highly specialized fields. With a passion for professional development, she has been instrumental in pushing for a Certificate of Added Qualification in interventional radiology through the NCCPA, an initiative that will help define standards and elevate recognition for PAs in this growing specialty. Beyond her clinical expertise, Carrie is actively involved in leadership and mentorship within the PA community. She has played a key role in the Society of Interventional Radiology, working to strengthen the presence and influence of advanced practice providers in the field. She's also engaged in the Entelios Foundation, an organization focused on medical imaging excellence, and has been a vocal advocate for fluoroscopy and radiation safety standards. Through her mentorship efforts, whether speaking at conferences, guiding PA students, or connecting with aspiring PAs through professional networks, Carrie is shaping the next generation of clinicians and ensuring they have support and knowledge to thrive. In this episode, we'll dive into her journey, her efforts to expand PA opportunities in interventional radiology, and the impact of her work on the profession. Whether you're a PA student, a practicing clinician, or simply curious about the future of PAs in specialized medicine, this conversation is for you. Please keep in mind that the content of this podcast is intended for informational and entertainment purposes only and should not be considered as professional medical advice. The views and opinions expressed in this podcast are those of the host and guests and do not necessarily reflect the official policy or position of any other agency, organization, employer, or company. This is Shadow Me Next with Keri Hayes. Hey, Carrie, thank you so much for joining us here on Shadow Me Next. I am thrilled to have you. I have never met somebody who does what you do as a PA. So thank you so much for joining us.
Yeah, thanks for having me. I'm super excited about being here. This is great that you're doing this Shadow Me Next. I think it's a really unique opportunity for people. It allows us to kind of brag on our specialty a little bit and then also to sort of, cause, PAs and Ps to think about, interventional radiology, that sounds cool.
I'm so glad because that's exactly what we're doing. We're bragging on our specialty. It was funny. One of the guys I just recently spoke to, Jim, he said, Ash, what I do is so cool. And I just want to share it with everybody. This is going to be a really interesting conversation for pre-health students to kind of discover something else that a PA can do, and perhaps a really eye-opening discussion for current practicing clinicians. Because like I said, I think what you do is really unique, and we all have a lot to learn from this conversation today. So Carrie, let's start from the beginning because you have a really interesting story even before your PA career. Tell us what inspired you to pursue a career in medicine, and where did you end up initially?
Well, I guess like all young girls, I thought I'm going to be a veterinarian. Of course. That's what we were all going to do as little girls. That's sort of the first part, right? The second part is that I grew up in a really small town in North Carolina. And when I say small town, I mean really small, little to no access to specialty care, like no real preventative medicine. Like you only go when you're sick. Mm-hmm. You're not just going to go to be proactive. Sometimes people couldn't even afford insurance. And when folks were getting to the hospital, it was normally an acute state, some advanced stage of disease, low health literacy, just really few community resources. Our closest specialty centers were 2 to 3 hours away. It was often a hardship to travel. This has a huge impact on outcomes for folks. So I've always felt drawn to low resource communities to be a patient advocate, but how could I bring specialty services back to my small community? So that's I've always known that I was going to take care of people, but I was especially invested in making sure that there was some equality in the care. So that is how I decided I wanted to be in medicine. But then from there, I thought I would be a veterinarian, but now I'm an interventional radiology PA in Oregon. So of course, it makes perfect sense how I went from there to here.
A little bit of a wild journey. Absolutely. Absolutely. It's funny. Veterinary care, I spoke about this again. I mean, there's so many connections in medicine. It's so fun. But I spoke about it with a pediatric resident physician recently, and caring for animals and caring for people is still caring for another living thing, and she told me about how much she had learned working as a veterinary technician and how a lot of her patients as pediatric patients, she uses very similar techniques with them because they don't speak. Most of her animal patients also did not speak. They have different ways of expressing themselves. Keri, you worked as a medical sonographer before PA school. Is that correct? Tell us a little bit about that and what that transition looked like.
Yeah, that's so funny that you bring up what you did because, while I thought I was going to be a veterinarian, I ended up working with a veterinary radiologist group. 2 radiologists owned their own practice. We were mobile. We went to veterinary hospitals and clinics and did diagnostic and interventional ultrasound. And I became obsessed with ultrasound. Like, oh my gosh, you just put this on their belly. And oh my gosh, you could see all these things. So it was while I was doing that I fell in love with ultrasound. And then I thought, okay, I can do this with animals. I want to do this with people too. So that's how I ended up going to ultrasound school. It's like, okay, I want to scan people. And then while scanning people from 24-week preemies to 100-year-old patients, I hit this glass ceiling of like, oh man, like what happened to them? How did that turn out? Was my ultrasound correct? I really want to know what happened. That patient told me about something that was going on with them personally. How's she doing? She was so sweet when I saw her. So that glass ceiling sort of propelled me forward. Okay, I want to have an established relationship with patients. I want to be part of a longitudinal care aspect. So that's how PA school happened. I got into Duke's PA program and I hit the ground running. My first job was in Houston. So that was an interesting transition going from being a sonographer to PA school to now being an IRPA, where I'm not only using ultrasound in a diagnostic capacity, but now I'm using it in an interventional capacity. So yeah, it seemed like a logical step for me.
It's a very interesting tract, really. You saw what you were interested in, and then you've really stayed close to that field at least, but your responsibilities have changed. And what your abilities, what you can do has changed. How is Duke's PA program? This is one of the best, if not the best PA programs in the country. Super challenging, I would imagine.
I think they tell you, I went into it thinking, yeah, I'll probably still work part-time. No way, man. And they made you sign a piece of paper that said you wouldn't work in any capacity more than 15 hours a week or something. Yeah. It definitely became a full-time job. That we've all heard this, like drinking information through a fire hydrant. Yes. I mean, it was really literally, I think there was one morning I had been studying I would go to school, come home, I'd study all night, I'd go to sleep, I'd get up, I'd study, then I'd go to school. I think there was one morning where I had studied so hard for a test that I went out to my car and I could not remember how to open the door to my car. Like, where is it? It was just, my brain was so full of other things. Like I had forgotten how to open my car door, but I have like a core memory of that moment. It's like, Carrie, just breathe, it was fine. But a great program. We had patient contact really early on. I really feel like they prepared us to be clinicians. So I'm very proud of my time there.
That's awesome. No, it's so true. Our brains, we become so focused on what we're studying and trying to not just pass our tests, but really retain this knowledge so it sticks.
Yeah. And I remember them saying, the goal is not to remember everything. It's to remember that thing exists. and to know where to go get that information. And that was super helpful to me. But, it's also put me in a unique position now for new PA students when they are messaging me saying, oh my gosh, I'm studying for blah, blah, blah test. It's like, you know what? It's going to be a blip.
Yeah. Ask us in 10 years and what we're doing. And if we remember, any of those exams. So Keri, when you were on rotation, when you were doing rotations in PA school, did you have access to an interventional radiology rotation, or did you just know that you were interested in that?
Well, I leveraged my network at Duke Hospital because I was a sonographer there. And so I went to, and a lot of the physicians that I work with, a lot of the radiologists, they were very supportive of me going to PA school. And so with my program, you could pick 2 rotations and you could create one. So I went back to my IR, folks at Duke and said, hey, can I create an IR rotation where I can come and be an IR PA student? And they said, oh, yeah, great. So I set that up, actually. And so I got to go and spend, that rotation there. So I got to actually do some thyroid biopsies and do some other things, be more hands-on. But the trick was that they had to continue to offer that to other students, right? So once you create it, it has to be maintained. So yeah, that was how I solved that riddle. Not everybody has that opportunity. Not all PA programs allow that. And then I would also, even when I was a PA, when I was in my first job, sometimes the PA's students that were on surgery rotations would come hang out with me, come spend time with me. But I think there are more of them now than there used to be, where you can have a rotation. But as far as fellowships go, I think there are maybe 1 or 2, maybe. But when you Google that, it doesn't just pop up. So I think in general, you're not really getting a lot of IR exposure. I think you're going to get some radiology lectures, but you're not going to get a lot of IR exposure.
Exactly, which I'm sure is where your background and, like you said, your network came in such handy. It's the cool thing about being a PA. We have access to all of these different fields that we can jump into, and interventional radiology is one of them. You mentioned a thyroid biopsy, and the medical nerd in me is freaking out now. So excited to talk about a day in your life. Keri, walk us through what it looks like to be an interventional radiology PA. Now we know you do thyroid biopsies, and I'm sure that's just the beginning.
Just to kind of start it off, we're image-guided interventions, image-guided procedures. So we're clinical and procedural. So we're either intervening in a clinical capacity, meaning we're trying to find an answer. So maybe like a targeted biopsy of the liver with a mass in it. Was a common procedure I might do, where that's answering a question. The oncologists need to know what kind of cancer they're treating to go to the next steps, right? So it's a unique intersection for you to build a relationship with a patient because they're often scared to death. We often become sort of a landing pad for a lot of questions because they get pretty hurried and rushed through this process. It may be that their primary care did some lab work, it was abnormal. They messaged them on the portal and said, hey, I'm sending you for this liver biopsy. By the time they get to me, they're like, what is happening to me? So it's a unique intersection there. So it allows us to be advocates for the patients and to sort of normalize what's happening and say, hey, I'm here rooting for you. This is what comes next. Let me make sure all the connections are in place for you. So there's a lot of that. We offer treatments that allow people to walk in feeling badly and then leave feeling better. A joint injection for someone who's has osteoarthritis and they just can't lose the weight they need for their knee replacement or whatever it may be, or cancer patients who've had radiation who have pain. Just this year, I've had the pleasure of taking care of 2 women who are in metastatic, like stage 4 cancer. Their biggest complaint was shoulder pain, just their shoulders hurt, just the tenseness in their body. And they said, no one's been able to make this feel better. Little things, doing a suprascapular nerve steroid injection or trigger point injections. These women were in tears when they left because they felt better after a year. So it's that, right? It's answering the question, but also making it more manageable. So I like that, in one day, a patient can arrive. We don't know what's wrong with them. I can do an ultrasound. I can say, hey, there's a liver mass. All right, I'm going to do a biopsy of that liver mass. This is all on the same day, right? You don't even have to really be fasting in some settings. I get that answer. It's off to pathology. Within a day or 2, we have an answer about what that is. And then maybe 2 weeks from now, you come back to me for your port placement because you need chemotherapy. And then maybe farther down the road, you've got, refractory ascites that I can now take off for you palliatively to make you more comfortable. So being able to intervene at these places where this specialty care is really needed is pretty exciting for me. I like making people feel better, and I like solving the puzzle.
That's the coolest thing about working procedurally and also clinically as well. You get to use your hands, you get to fix the problem, but also you have that interaction with the patient that is so wonderful. And arguably one of the reasons why we became PAs, right? Oh, Carrie, there are so many different ways I want to go based on everything you just said. First, I want to talk about your autonomy. And this is probably going to lead into a question about how you work in a group setting, right? How you collaborate with radiologists and technologists and other healthcare professionals. You mentioned, even primary care doctors sitting patients in, that sort of thing. What does your autonomy look like in interventional radiology, and how do you collaborate with other members of the healthcare field?
It's different. I mean, I think you ask PAs, nationally that are in IR, they're going to tell you, "Hey, I'm only clinical." One's going to say, "I'm only procedural." One's going to say, "I'm a mixture." We use these terms, like a physician surrogate versus a replacement. I think in my role, in my years of experience, I enjoy working in the outpatient setting. So outpatient-based labs, I like that setting. It can be very, very fluid. You can get a lot done. But for me, I can be pretty independent. I mean,
Mm-hmm.
I have that support that I know my attending's in the other room or he's a phone call away. But for the most part, they trust me. And I also know that if I need them, they're going to be there. So they do allow me to practice within my full scope, which I feel very lucky about. I work in the state of Oregon right now, and it's very PA/NP friendly. So there are not a lot of limitations in that standpoint. But, one of the unique things about my practice is that we have diagnostic radiologists. Those are the folks who are spending time in front of the computer screen, reading CTs, MRs, et cetera. And you have interventional radiologists. And in the last several years, it used to just be radiology, and they've separated. So for a private practice, it's more, from that standpoint of generating RVUs and keeping the doors open for patients. I can see, the paracentesis, the thoracentesis, the consultations for cancer treatment, the women's health consultations, the problem visits, the catheter exchanges. I can see all of that while he's able to read these high-level acute CTs and MRs and X-rays and get people answers, like keeping the wheels turning. So if he were to be pulled away from that reading, then someone like you or me is waiting to find out what mom CT said, or waiting to get that answer so we know what to do next, or that patient who's now finished chemo and we want to know, did it respond? Is the cancer still there? It allows them to keep answering those questions, right? We're keeping the other part going. So I've been fortunate enough in practice to be very autonomous, but also like knowing what my limits are. So if I call and ask for help, they're like, okay, something's up, right? And they've learned to trust me in that way. It's definitely, I think, can be a little bit harder to build that in a procedural specialty because of the liability.
I absolutely agree with you. And Carrie, you just beautifully described how a PA working at the top of their license in conjunction with an attending who trusts that PA is so efficient. Once you've developed that trust and that relationship with your attending physician or your supervising physician, when you call on them for their opinion or for advice or for help, they respond. They know that you know what you know, and they're also aware of the fact that you know what you don't know as well. And that's equally as important, right?
No, it's true. It's true. Something as simple as a paracentesis, we'll take that fluid in the belly. We need to take it off. That's something I was doing 25 of those a day at a prior practice. And I had a patient come in, really complex history, cholangiocarcinoma. We're seeing frequently for various drains, catheters, tubes that he had. But when he came down for paracentesis, I thought, this just looks funny. Like the fluid doesn't look normal. Something's not right about it. It just bothered me. And I think as PAs, we have that little voice that says, something's not right here. I need to go get somebody. And that's the beauty of being a PA, right? Is that you always have that person that you can go grab and say,
Yes.
look at this with me. I love that. And that's why I became a PA. I mean, I think there are misconceptions about, well, you couldn't go to medical school or you weren't smart enough. No, absolutely not. It was just not that at all. I like the team. Like, I want to have a group of people. I'll be better having that support. But yeah, I went and grabbed one of my attendings. Now, keeping in mind, I've been doing these for years and years, thousands and thousands of these procedures. And I went and grabbed him and said, hey, this does not look right. So he kind of rushed in and was looking around. He's like, oh, wait a second. Yeah. And what had turned out is that this patient had a gastric outlet, he had a gastric outlet obstruction. And so what I was actually, what was like funny looking fluid was actually his stomach because they had two
Wow.
stairs. So he was in trouble. And, and afterwards, the radiologist put me to the side and he said, I got to be honest. I probably wouldn't have caught that. I probably would have just done it. And then that would have been a whole other situation. But it's in
Yeah.
that moment where I took the chance that he was going to go, oh, it's fine, Carrie. Like, she should have been able to do that. But instead, it was a winning moment in his eyes because she's going to come get me and I don't worry about it. So yeah, I think that's what I hope for every advanced practice provider, but I think we ultimately are a product of the investment of our collaborative physicians, right? If you invest time in us, we're going to be great. If you don't, we're not going to be great. We'll have our own way, but we were created to help extend them, to help make their day easier and to just have better access for patients. So with physician shortages, especially in radiology, I am a product of a lot of great radiologists and mentors.
That's incredible. Some of us work very, very closely with our attendings, with our supervising physicians, and others don't have that opportunity.
Mhm.
And while I think they can still be incredible PAs, they will also tell you that perhaps their road to where they're at was a lot steeper, a lot scarier,
Yeah.
and a lot less supportive, period. I think the confidence that I have in my practice has largely come from the fact that I have significant access to my supervising physicians. Something you mentioned, Carrie, that I would love to go back to just because it's interesting is when you have patients come in, you mentioned some of them come in incredibly fearful because they're there. Somebody told them there is something wrong with their body and they are there to find out what it is and how wrong, how bad it is. And then other patients come in and they're so hopeful because they found out maybe you can help them with chronic pain or with a chronic disease or chronic issue. How do you manage that? How do you address the patient's emotions going into this?
I think that's probably one of my favorite parts, because you have patients that are afraid, of course. You have patients who've been in chronic pain for a long time, and that changes people. And then you have people who've just sort of given up. You have people who haven't really been heard, that feel sort of hopeless. And then you have the people that you walk in the room and they're very skeptical. They're very skeptical of you. They've had bad experiences, and maybe they're skeptical of you because you're a PA or an NP, not a
Mm-hmm.
physician. So being able to walk in the room, establish a rapport and win them over, where at the end they're saying, "Oh, can I get your card?" I like that. I like that opportunity to get in there and reshape the way they're seeing it, as a more of a victory and less of a setback. That we're going to make that better. We're going to work on making it better. And if we can't, we're going to get you connected to the next step. Because sometimes that's what I'm doing. Hey, I can't fix this or make this better, but I know who can. And I'll take that responsibility of getting you to the next step. When patients come in the room, they trust you. They're very vulnerable to you to share this sort of problem. So I think we take that for granted as providers. They're our seventh patient today, but this is their unique situation. So it's very important for me that I walk in the room knowledgeable about that patient, especially the skeptical ones. And you never know when you're going to hit the skeptical ones. But when they start sharing past experiences, when they start sharing other things that have happened, you need to be able to say, yeah, I read about that. That must have been really difficult. Or, what about this? I had a patient who needed a biopsy, a lung biopsy done, but he kept canceling. He wouldn't get the biopsy done. And I said, let's bring him in. I want to sit and talk to him. This guy was in his 70s, sweet guy, but was very withdrawn, very shielded. I could just tell. I was like, hey, it's really important that we get this done for you. So I want you to talk to me. What's happening? Tell me. And you could tell as an older man from a generation of not really complaining or being upset, it was hard for him to talk to me about it. And I said, are you afraid it's going to hurt? Are you afraid that, you're going to pass away? Like, what? Tell me, talk to me. And so he shared an experience when he was a kid. This was many, many years ago. He was probably 8, 9 years old, maybe. And it sounds like he had pneumonia and he had pleural effusions. And so he said that daily someone would come in the room, hold his arms, and they would drain his chest. And they did that for days. And so he has trauma. He has trauma as a man in his 70s, and that trauma is preventing him from getting his lung biopsy. So I needed to create a space where we could talk about that before we could even get to the risks and benefits of a lung biopsy. And so what I was able to zero in on is, okay, he needs to feel like he has some control, and he needs to know that it's not going to hurt. And we need to deal with his anxiety surrounding having the procedure done. And so we laid out a plan that he felt good about, and we got it done. And we're able to move on to the next step. But sometimes you think you're going to go in and talk about a pneumothorax as a risk, but instead you've got to hear them and say, that's awful. That should have never happened to you. And nothing like that has happened on my watch. So it's interesting how I think you have to be prepared for whatever you're going to walk into. But I love when patients can be that way with me. I love when they come in afraid and feel overwhelmed by it, and we make it more manageable together. I like that.
That is such a great story. And those stories, believe it or not, those stories usually do have happy endings. I have found, at least in my practice, it's inevitably the patients, when you walk in the room and the temperature literally drops, they're so reserved and they're so protected and guarded. And being able to disarm a patient like that with your words and your questions and maybe a physical touch if it's required is so rewarding. It can be exhausting if you have to do that multiple times a day.
Yes, that there is a cost to that, to become that emotionally invested, right? Especially in IR, we deal with a lot of palliative patients. So, sometimes you're going to get asked those tough questions. Why is this happening to me? I've accepted what's happening to me and I'm ready to go, but I don't know how to let go. Like, I don't know how to die, Keri. Like, how do I even do that? My husband isn't ready to let me go. You got to talk to him. So sometimes you get asked these questions, especially around procedures and interventions of, is my mom going to make it through this? They'll bring daughter and granddaughter and sons. And so you're not just treating the patient, you're often treating the families too. I think it's just being really clear about, how we're going to help and how we're going to address all the other things too. Because maybe they're coming to me for liver-directed therapy for a tumor in their liver, but they also really need a nephrologist because their renal function is not great, but they don't have a nephrologist. So now, okay, I got to get them safely to that next destination, because it's more than just I do IR. And I think that's different. It's different for everybody. But for me, it's all encompassing. In my current practice, I'm working with advanced vascular centers in Portland, and we do a lot of women's health, but a lot of limb salvage, like preventing amputation. And these people come in afraid. Someone going from being able to walk to not being able to walk, what an equalizer, right? The morbidity and mortality associated with patients after that happens, we got to fight really hard for them. So, how do we intervene at these acute and scary times in a very valuable and meaningful way so they buy in, right? You got to get buy-in.
You do. Carrie, you've talked about some really mind-blowing things that you get to do and ways that you get to help these patients. Thinking back when you first started PA school, or maybe right after you graduated, is this what you thought your life was going to look like? I mean, do you take a step back every now and then and go, oh my goodness, look at what I am doing right now. Look at how amazing this is.
Like I said, I think I knew I always want to take care of people, but I didn't know that this is where I would end up, or how it would end up. When I knew I wanted to be in radiology as a PA, I only knew one other one. I was in North Carolina. I had never lived outside of North Carolina. So I didn't know any other ones, but I thought, oh my gosh, we need more of these. So I kind of set out in this unfamiliar territory and thought, if I can at least land safely in some of these spots, then there'll be a place for others to land safely. And so it's been really cool seeing more and more and more of us, and then there were people doing it before me, but I didn't know how to reach them or connect with them. So now going from being the only one I know to being in a room with 200 of us, it's pretty amazing that you can say, hey, this happened or that happened. They're like, yeah, I know exactly what you're talking about. So that feels pretty awesome. And then, increasing access to patients, because especially from the small community I came from, there's no one like me. I also have become sort of that center hub for a lot of people that know I'm in the medical field that will reach out like with a question or a concern. I don't always have the answer, but I can at least point them in a direction. So yeah, it's been really cool. And then when I have someone message me on LinkedIn and be like, "Hey, it looks really cool what you're doing. How did you do that?" I mean, this mentorship idea, any chance I get, if someone says, "Oh, like we had an equipment vendor said my son's thinking about going to PA school. Hey, give him my cell number, have him call me." Or I'm working on my letter for PA school. Send it to me. Let me look at it with you. Can I do a workshop for the PA class? This is when I was at Stanford. Yeah. Okay, let me do that. I can't wait. Make a workshop. Any chance I get, like what you're doing. I love this, being able to talk about it, not just as an IRPA, but as a PA in general, because I wish this resource had been available to me, or I knew how to access it when I was coming through.
Right, exactly. And, speaking on professional development, what you do is amazing. And the fact that you realize that it is growing, but it has so much farther to go
Mm-hmm.
is pivotal. And this is a perfect segue. I talked about a bunch of the other things that you're involved with in the introduction, but this is
Yeah.
a perfect segue into talking about something that is so interesting that you are involved with. And it is creating a certificate of added qualification for interventional radiology. This is through the NCCPA, which maybe we can talk a little bit about CAQs. I have one in dermatology. They're specific to our field of medicine. Tell me about how that process is going for you. Before we hear about this incredible experience that Keri is having creating the CAQ, I want to talk to you about quality questions. This is a segment on our show where we ask these leaders in medicine that we are talking to if they have ever had an interview question that has been extremely memorable. Now, Keri and I did not have the opportunity to discuss a quality question. However, her conversation here about CAQs brings up a fantastic opportunity. This is directed at pre-PA students, but if you're a pre-health student that's interested in a different field of medicine, this can be directly applicable to you as well. A CAQ, or Certificate of Added Qualification, is a certificate that you get after you achieve your degree. So in this case, my quality question would be, do you believe specialty certifications are beneficial for the future of the PA profession, or insert your profession here? Or do they create unnecessary barriers? It's a great question to think about before you go for your own interview. Keep in mind that there's more interview prep, such as mock interviews and personal statement review, over on shadowmenext.com. There you'll find amazing resources to help you as you prepare to answer your own quality questions.
It's interesting. I think first off, figuring out why it makes sense, why we'd want to do it, wanting to be, I think because radiology for so many years was just considered a procedural specialty. We are a heavily clinical specialty as well. We're more, you send a consult our way for an intervention, then we've got to look at the patient holistically and say, this is a good idea or not a good idea for them. So we're a part of that multidisciplinary care team, right? So we are a heavily clinical specialty, but I think we're still viewed, for those that even know what we are, as a procedural field. So this is a way to demonstrate clinical proficiency in this specialty as a PA. So this certificate of added qualification, as you know, is created within the specialty through NCCPA, and it's basically a way for you to say, I have taken extra time and paid extra attention and put extra efforts towards demonstrating my proficiency in this specialty. And I think that it's time for us to do that. I mean, we are still a small number. I don't know. Do you know what percentage of PAs and NPs are in dermatology? Do you have ways to get those numbers? Do you know?
I'm sure we could figure it out. I don't know off the top of my head, but it's a larger percentage than PAs in interventional radiology. I can tell you that.
We're in that probably 1%, 1 to 2% of PAs nationally that are in IR, very small number, but growing, growing. There's more and more interest. We have folks leaving other specialties to come to us, et cetera. So the CAQ is a way for us to show others, hey, IR is my thing. And it's important to me. It also demonstrates to others, I think if you're a person who says, well, what does an IRPA do? Then you've got this blueprint that says these are the things from a knowledge-based standpoint. This is what they are expected to know and be familiar with. It's not saying that I'm proficient at placing a port. It just says that I have knowledge of this and I know what it's about and I know the pertinent key things to do. It's not a certification. So I think we have to be really mindful about that. There's some concern that these say that we can do things that we can't do. I can place ports, but that's more than a CAQ. Like that's mentorship, that's
Right.
years of training. So I think it's a way, and also to demonstrate to other providers, like say you're an IR physician or a radiologist has a private practice, and you've got a list of candidates. Like, hey, okay, great, this person, has a dedication to this field, so it might give you the upper hand as a PA or an MP as you're like fighting for that role. But interestingly, I need an endorsement from sort of our governing body or our specialty organization, that Society of Interventional Radiology. So I'm still in the process of getting their endorsement. It's just taken longer than I thought it would, but we're just wanting to make sure that we think of all the things. And the place I'm at currently is obtaining physician champions to be collaborative and support me in it. And we're probably going to be meeting for a SWOT analysis. So it gets it's important though. We want to do it the right way. So, I mean, this is down the road, but it'll be really valuable once it's done. And
It is, Carrie.
I'm not giving up.
You've already done so much for the field of medicine alone. And then for the field of medicine for PAs, the fact that you're working on this, number one, after talking with you and now knowing so much more about interventional radiology than I did before, it is absolutely needed to have a CAQ in interventional radiology. Really, like you said, it's just proof that you know what you know. This doesn't train you any better. I mean, really, this is going to sound silly, but really getting my CAQ in derm was quite easy because it was all the stuff I already knew how to do, right? The test questions were questions I knew the answers to because I've done this for 10 years,
Yeah,
so it's just a proof.
Yeah, and I think for us, because IR is very specialized, we have folks that just do neuro IR, we have folks that do interventional IR, we have women's health, we have men's health, we have diagnostic, we have so many different areas that it may be that a PA or an MP may just be practicing in a certain one. So when you look at getting the CAQ, it's like, well, hey, you're going to have to know some things about neuro IR, and you're going to have to know some things about all the different sections. So the beauty of being able to create it, having an expert panel convened, physicians included, to come up with the blueprint, the questions, all of that stuff, will make it, difficult or challenging, but fair, right? And it gives some people a better understanding of, well, how does Carrie know how to do that, or how do I know Carrie can go sit and have that conversation? Well, here's an additional demonstration of that. I would be super proud to have it. It's definitely not, it's an investment in me, but it also demonstrates my commitment to my specialty.
Carrie, as we wrap up, let's speak directly to someone who's interested in pre-health, right? I mean, you've seen healthcare from a variety of different standpoints right now. What advice would you give them as they're looking towards their future, considering a career in medicine? They're hearing all of the challenges and everything about burnout that everybody's talking about. In my opinion, it sounds like you are still super passionate about clinical medicine. So tell me what you would tell them, what you would tell those students.
You're either going to feel drawn to it and have a calling to it. I mean, I think that's important. first off. I mean, just saying, oh, well, I could be a PA. I mean, I think starting from a place of I really want to make a difference and I want to make things better, that's an important place. I mean, I think there needs to be something about it that speaks to you or drives you just from the beginning. But I think medicine is just, for me, it's been very rewarding. I mean, I wouldn't change a thing. It changed me. It changed the way I see the world. The relationships that I have made with, other providers, relationships I've made with patients. I mean, it's part of who I am now. And it was finding an outlet for that part of me that wanted to care for people. So I think it needs to be meaningful to you. If you're thinking about being a PA, it needs to be meaningful. It needs to come from a meaningful place. And I think we as PAs have a responsibility to mentor and support those people when they're talking about it. There are very traditional ways to mentor. We know preceptorships, I've done that, but there are also really like non-traditional ways to mentor. And that could be, again, just a phone call or responding on LinkedIn or talking to that vendor's son. Talk to them on your way home from work. Send them an email, anytime you get a chance to do that. But I would say if you want to get into medicine, it needs to come from a place of meaning for you. And with the burnout stuff, gosh, I'm so much better at giving advice about that than I am taking advice about it. You know what I mean? Like, oh man, you really need to have some self-care. Like you really should, gosh, like forget it. I'm like terrible at it. I'm terrible at that. I'm terrible at being a patient. Like I'm just terrible. So I have no credibility, but I know it's real. I mean, I would say I probably felt it the most and hardest during COVID and then after COVID. And I don't know that I've gotten back to where I was pre-COVID. And I don't know why exactly that is. We were still doing the same medicine. I mean, I was still, front line, still taking care of patients. I think it's because in my specialty, we didn't get to take a break. We just still had to be there. So I never really had a mental break from it. But yeah, it definitely has impacted me as a person and a provider. And it caused me to say, oh, I'll have that house in the mountains one day, or, oh, I'm going to get that Jeep Gladiator that I really wanted. I got my house in the mountains and I got my Jeep Gladiator. So like, don't wait on those things for, when it's less busy at work, go do those things, take the time off. Right.
It's great advice for pre-health students, but that's also really, really great advice for current clinicians too. I think that's incredible. Thank you so much for taking your time, your valuable time to join us on Shadow Me Next. As promised, you are just a wealth of information, and I'm so motivated by what you're doing for PAs now and what you will continue to do. That CAQ is going to be great. I know it's going to happen. So thank you. Thank you for what you do, and thank you for joining us today.
Yeah, thank you for your time. It was awesome.
Thank you so very much for listening to this episode of Shadow Me Next. If you liked this episode, or if you think it could be useful for a friend, please subscribe and invite them to join us next Monday. As always, if you have any questions, let me know on Facebook or Instagram. Access you want, stories you need. You're always invited to Shadow Me Next.